It depends on the situation, though, obviously, you know?
Yeah, sure.
So I see Dr. Tak is on mute, but I haven't seen him in a very long time either. There he is.
Yes,
yeah.
Hello, Duane and Dr. Dũng. Hello.
Hello.
Hi.
So I heard that in Boston, the situation is under control.
It is, I think. You know, the issue is that, you know, we admit 10 or so patients every day. About 1/3 are in the ICU, maybe a little more, a little less. But because the patients stay for 2-3 weeks, it becomes full. And so we have about 100 or so ICU patients who are all intubated. And we usually only have 50 ICU beds. And that is surgical ICU, medical ICU, cardiac surgery, cardiology. Now, all of the ICUs is COVID.
You talk about BI or Boston?
Beth Israel, just our hospital. But our hospital is similar to the others. So basically, all the ICUs have become COVID. We're not doing anything besides that. And there are about 30 or 40% of the patients are in the ICU intubated. And you might have heard that we put this has been going on since March, and we just put our first patient on ECMO today.
All the patients in the ICU needs the respiratory.
Yes, the intubation. Yeah, respirator.
Pneumonia.
Yeah. In fact, you know, I'm going to try to pull up an X-ray of the person I just put on. I'm going to just stop the video for 1 second. I'm going to see if I can pull it up.
Glad to have a presence of Professor Duane Pinto, Professor of Medicine at the Harvard Medical School, the Chief of Interventional Cardiology Section, the Director of Cardiac Intensive Care Unit at Beth Israel Deaconess Medical Center, Boston, and the Governor of ACC Massachusetts Chapter. And I am Professor Hồ Dũng, the President of the Vietnam National Society of Interventional Cardiology. Today we have many participants, internists, cardiologists, medical school from Ho Chi Minh City, Hanoi Capital, Perth City, Cần Thơ City, and particularly Tân Tạo University School of Medicine. So the first, we like to hear the case presentation from medical student of Tân Tạo University, please.
Yes, can you hear me well? Hello?
Yes, we can hear you well.
Okay, good morning, Dr. Dũng, and good evening to Dr. Pinto and Dr. Tak. Today I will present you a case.
You have to show the slides.
Yeah.
Chưa có slide chứ ơi.
Yeah. So today, me and one more student, Lộc, will present this case. So my case is this 73 years old white male who presents with chest pain at 8:29 a.m. In the 14th of April. So his history of present illness is he presented with acute onset sharp epigastric chest pain radiating to the back and left shoulder while he was sleeping, but his pain doesn't have any aggravating or relieving factors, and they did not improve since he had the pain until he was admitted. He did not have any dyspnea, autopnea, fever, or diaphoresis. His past medical history includes his hypertension, dyslipidemia, vertigo. He underwent cholecystectomy and LASIK surgery. He has no known allergy and no significant family history. This is his current medication. And he is a former smoker. He used to smoke 75 pack years, and he has quit since 1995. He doesn't use alcohol or any illicit drugs. He has limited physical activity daily. And his review system is insignificant, but for the fact that he has a chest pain that was mentioned earlier. His vital sign upon admission was his blood pressure was 107/65. His pulse was 100, and his BMI was 31 kilograms over square meters. And also his examination has no significance characteristics.
Maybe we can take a pause here.
Yeah, okay.
And let's just go back to the history.
Okay.
So what do you, and maybe anybody on the call can comment on the most important findings of the history and what's helpful and what's helps us rule things out.
How about
Min,
your?
what do you think?
Yes, I think
we're going to have to call in Dr. Tak if nobody answers.
Can I answer this?
Yeah, please.
So we have a case of 73-year-old male patient with past medical history of hypertension and long-term smoking history. And now he came to the hospital because of chest pain, epigastric pain. So we need to think of the severe or dangerous causes. So it may be MI, it may be some kind of aneurysm or dissection or anything like that. So we need to rule out those dangerous causes first, and then we can think about more causes in the abdomen.
Yes, of course. So those are the two major ones that we worry about in the emergency department: aortic dissection, myocardial infarction, pulmonary embolism are the kind of three that are always on our minds. But we can't. First of all, we can't always only rule all of those out every time. But we have to think about some clues in the symptoms of what it is, and in the history and what it's not. So epigastric pain radiating to the back, that may make us worry because of the radiation a little more about aortic dissection. So when we're doing the physical examination, we would want to know what the blood pressure is in both arms. And the character of the chest pain is not typical for dissection, though. He described it as sharp, but very often it's very horrible pain that is described as tearing sensation. And then also too, in this case, there's not really any other signs of pulmonary embolism. He doesn't sound like he's short of breath. He's not got hemoptysis. And there's not any respirophasic or change in the chest pain when he takes a breath in or out. The epigastric nature of the pain makes you wonder about an abdominal process. The left side radiation makes it a little bit atypical, but the good news is he's had a cholecystectomy, so we don't have to worry about cholecystitis as the cause. We do worry about pneumonia and some irritation of the diaphragm on the left, but he hasn't looked like he had a fever. But now let's move on to the physical examination, because our history informs us how we're going to direct the physical examination. And we say that we would normally want to see what the blood pressure is in both arms, hear about the heart examination, and then also see what his chest configuration looks like.
Yes, okay. This blood pressure was taken in his right arm, I believe. wasn't taken in his left.
Mhm.
And
What would you expect the blood pressure to be if he had a dissection? And in both arms, what are you looking for?
It'd be uneven. Both are comparing both arms, uneven.
And which would be the lower one?
That depends on the location of the dissection.
Well, the dissection could be an ascending dissection, and then both the brachiocephalic artery and the subclavian would be involved, and they would be both low.
Yeah.
But if the dissection is close to the left subclavian, then the brachiocephalic artery is spared, and the left arm would be lower. So typically, if there's a type B dissection, it's the left arm that is lower than the right arm. And if it's an A dissection, ascending arch, then both are involved.
Yeah. Okay. His cardiac.
And I'm just going through this just to be complete. This history doesn't sound like he's having a dissection, but just in general.
His lungs and then cardiovascular system seems normal in examination, as well as his gastrointestinal tract.
Mm-hmm.
So in summary, I'll show you the labs later, but in summary, I put in the labs also. A 73 years old white male presents with chest pain, and his symptoms includes a sharp epigastric chest pain while sleeping, radiates in the back and left shoulder with no aggravating or relieving factors. His medical history includes hypertension, dyslipidemia, and he has underwent cholecystectomy surgery. His blood pressure is 107/75, and his lab shows the leukocytosis. His white blood cell was 19.93 thousand over microliter in normotropic. His EKG in ER was normal, and at 11 a.m. the patient was admitted to ICU to rule out MI. So
say you were the doctor in the ICU, in the emergency department. What would you treat him with? And there's one finding that we skipped, is that his heart rate is 100.
Yes.
So, there's something that's not right, there. That's, something that I would pay attention to. But what were the medications, and what kind of was the initial strategy coming out of the emergency department?
Usually we can put free 25 milligram aspirin for the patient if you think about MI.
Mm-hmm. That's it?
No, of course, pain medication, anything. But it's weird for this case that he was admitted to IMCU. I just don't understand at this point.
Yeah, I mean, the diagnosis seems somewhat opaque still. He's not at least for coronary syndrome, he's not high risk. His EKG is normal. His troponin is normal. I think, if you really were worried about him having acute coronary syndrome, you might anticoagulate him. I think it appears as though he's low threshold for really having an MI. I think if he was tachycardic and such, and we thought this was leading to some demand ischemia, we would give him a beta blocker. But his blood pressure is a little low, and his heart rate's a little high, and his white blood cell count's a little high. I'm worried that he's infected.
So what do you think we should, like lab tests that we should give him to investigate the reason, the causes?
But you tell me.
Yeah, I would give complete blood count, comprehensive metabolic corner, troponin, and maybe he's troponin again in 3-4 hours.
Yeah, I think those are good blood tests to start with, but they probably got that in the emergency department. That's why we know his white blood cell count is 20.
And to rule out dissection, maybe CT, chest CT.
Yeah, I mean, I think that's a judgment call of whether to get a CT or not. I think that the likelihood of dissection is low, but I mean, I would complete the physical examination and then make a decision yourself. Agree. I think, you know, it's very interesting. His history is that this is abrupt onset and no other symptoms, you know, fever or chills or any of this sort. So it's a little strange that it's, you know, so strange that he had abrupt onset. That's a little atypical for an infection. So I think, you know, on the chat, somebody is asking for a chest x-ray. I think it's nice to just start with that.
Yeah, chest x-ray also.
Even though his physical examination was normal.
And so here the lab results.
Hello, love. You can explain to everybody the results of blood tests and the result of the testing.
You go back one.
So his blood test only shows high white blood cells, and in pathology it shows.
Can you go back one?
Yeah.
So did he have a bleed overnight? His hematocrit went from 50 to 42. His hemoglobin dropped 3 points.
He did not have. He didn't have a bleed overnight.
With his, I'm only asking and posing the question because that's a significant difference. If he presented with a hematocrit of 38 and it went down to 30, we would say that he had a bleed, right?
Yeah.
So I assume that he was hydrated overnight and was dehydrated when he came in.
Okay. And more comprehensive path review, so it shows granulocytosis and lymphocytosis. This is the EKG when he was 1 year ago. And
what's your interpretation of this EKG? Anybody?
I think it's normal. Just only that the patient has very cardiac. That's all.
It makes it all the more interesting that his heart rate's 100 now. You see there are negative deflections in 3 in AVF, but very small R waves. So we wouldn't call this an inferior myocardial infarction, but the axis a little bit rotated.
oh, this is 1 year ago.
Yep.
And this is the time he was admitted.
I mean, you should go quickly because not enough the time.
So this is this
How
EKG.
you can match the diagnosis?
This EKG doesn't show much difference from the last one as well.
And it's also not a heart rate of 100, which was what we saw in his physical examination. Okay. Very similar.
Okay. And this is the metabolic panel, slightly high glucose. Nothing of significance. his urine analysis, and his troponin, as well as DNP.
Mm-hmm.
His chest X-ray. And since he has the left shoulder pain, he was taken an X-ray was taken of his left shoulder as well. And also a CT. The results shows only emphysematous change in the regular base and molar formation regular base. Because he was a former smoker, I guess. So nothing out of the ordinary. But at 4 p.m. in the afternoon, the patient complained increased chest pain, so a senior cardiologist was consulted. At the time, his heart rate was 110, and his blood pressure dropped to 86/66. So a second EKG was done, and this is the EKG.
I don't see V4, V5, V6, but maybe anybody can describe the findings in the inferior leads.
V4, V5, V6, we have SC elevation significance in V5, V6. You can turn off the video box.
And also 2-3 AVF.
Mm-hmm. So what do you guys think?
According to this, he might be having an MI, posterior, at the posterior wall.
Dưới.
Does everybody agree with that? What are typically the posterior leads?
The posterior leads are V2, D5, AVF, the V4R, V5R, and V6R. Yes.
Yeah, so, for the posterior leads, and a true posterior infarction is actually infrequent, but that's D7, 8, 9. So if you keep moving around the lateral apex, around to the back, that's 7, 8, and 9. Now, that's actually the mirror image of V1, 2, 3. So if you see ST depressions in leads V1, V2, V3, that's the posterior wall with elevations. The inferior lateral wall is 2, 3 in AVF, and the lateral apex is V5 and V6. The high lateral wall is 1 in AVL. So this is an inferolateral infarct involving the inferior wall and the lateral apex. So probably a large posterior lateral branch, but it doesn't really supply the high posterior wall or the high lateral wall. Okay, there's a little bit of ST elevation. You see minor amount in 1 there, and T-wave inversion in lead AVL, and that's new compared to his prior. So in the context of all of this, it's a little bit strange though. He came in with chest pain. His EKG looks fine, his vital signs are fine, and then all of a sudden he's got chest pain like this. What are other things you might want to think about besides regular myocardial infarction?
In this EKG, his voltage is very low, so we can expect effusion, pericardial effusion.
Yeah, maybe, but he shouldn't really have abrupt onset of chest pain with that. And his chest x-ray, didn't look like the cardiac silhouette was very enlarged. But when we say regular myocardial infarction, we think about an atherothrombotic event, so ruptured plaque and thrombosis. What other pathophysiology could there be with a normal EKG? All of a sudden he has ST elevations while he's in the hospital. Now this happened when he's come from the emergency department to the floor. What if you were to give him a sublingual nitroglycerin and his chest pain went away and the ST segment elevation went away also? What diagnosis would you wonder about?
Constrictive coronary constriction, I think. Prince metal, yeah.
Yeah. So you wonder, if he had dynamic EKG changes, I think it's reasonable to try some sublingual nitroglycerin with him. The other thing is, and I don't think he has pericarditis, but you see there's some PR depression in lead 2. It's not evident in the other leads. So what did the senior cardiologist decide to do at this point?
So this is a story, right? Wait. When the patient had the chest pain at 4 p.m., the ER they want to us to consider. So when we come there, I want to make sure that the patient really had the chest pain when he do the very heavy work. So I order the chest test. When the lexicon stress test, the patient continue have chest pain. But however, 1 minute after 1 minute with the lexicon injection, the blood pressure of the patient dropped to 86/50, and the patient continue to have a chest pain. So if you in that situation, what should we do next? Should we continue the chest test, or we should call the cardiac cath lab for the emergency coronary angiogram?
Let's go back to the EKG. Let's go back to the EKG.
Yeah, I'm trying. Yeah. Wait, no.
So you're faced with this patient who
Yes.
is having ST elevations and they're having ongoing chest pain. And I think, there's some questions of what do you do next? Should you get a stress test? How are troponins doing and things like that? I think at this point, you have a choice. You really have to make a decision of whether you're going to treat him as if he has coronary vasospasm or whether he really has an acute myocardial infarction with an occluded artery. And that's dependent in the next kind of 10 or 15 minutes, whether the ST segments resolve or not. And by the time the test results come back, if he's really having a STEMI,
Maybe too late.
you wasted too much time. So at this point, I would give him a sublingual nitroglycerin, repeat the EKG, see what happens to his chest pain. If it gets better and the chest ST segments get better, then you have the luxury of waiting a few more minutes and trying more nitroglycerin and maybe getting a a echocardiogram to see. I see that you have 5-minute troponins. We don't have point of care troponin here in my hospital. So we make our decisions without that piece of information. But when it comes to ST segment elevation, you either think it's an occluded artery, in which case the best place for that person is a cardiac cath lab, or you think it's not an occluded artery, in which case the best place for that person is in the cardiac cath lab to get an angiogram to show that it's not an occluded artery. This is not somebody you would give thrombolytics to because the diagnosis, I think, is still somewhat suspect. And that's how I would proceed.
And so we move on to this EKG. This is the EKG from the VAP in some stress test.
So the patient still has STS segment elevation. Is that right?
Yes.
So this is not a patient I would put on the treadmill and do a stress test.
This is the chemical stress test.
Yeah, I mean, I think for me, with new ST segment elevation, this person goes to the cath lab. I don't think we're going to get any information from a stress test that's going to dissuade me from wanting to know what his coronary anatomy looks like.
I think this guy in Vietnam, after we diagnosis ST elevation acute coronary syndrome, we must start the acute reperfusion therapy. If we done in COVID-19 pandemic, the best way send the patient immediately to the cath lab. We can do coronary angiogram first, and sometimes it can miss the diagnosis, and we know. But if we don't have a cath lab, in the guideline, it recommends that we cannot start acute reperfusion therapy, not wait to the result of the serial troponin test, because the golden time.
This person has no symptoms suggestive of COVID. Now, of course, they could be an asymptomatic carrier, but his main life-threatening illness is not COVID. It's myocardial infarction, presumably. So either we're not going to send him for reperfusion because the capability is not there, or we are. But a stress test is not going to answer that question one way or another. And in fact, just exposes more staff to the potential of a patient with COVID. So, but he's not had any symptoms. He's not had any fevers. And we have to be prepared in the cath lab to deal with patients who might be found to have COVID later. But that shouldn't dissuade us from doing what we think is the normal strategy. Again, I would reemphasize, as long as the cath lab is available, that's still the best place for the patient. If the cath lab is not available, or you're in somewhere in Vietnam or the United States where that patient is not going to be transferred to the cath lab in a timely fashion, it may take many hours. Or in our case, the cath lab is not available because it takes an hour or two to clean the cath lab after a COVID patient, then one might consider thrombolysis followed by angiography in 3 to 24 hours. But in this case, it seems like the cath lab is available. The patient still has ST segment elevation, so that's where he should go.
Yeah, I agree. We call it pharmacoinvasive therapy. This means we combination fibrinolysis therapy and send the patient immediately to the cath lab. And in this situation, I think the stress test is contraindication because it's very, very high risk for the patient in acute coronary syndrome. I think so.
That's right.
And as time goes on, but we decided to keep the stress test going, and the EKG starts to shift, and it shows PR depression. Oh, sorry. And it slowly shows PR depressions leads.
So, we typically say that PR depression diffusely with diffuse ST segment elevation is a sign of pericarditis. In this case, the ST segments are more pronounced, and in the setting of what we suspect is a myocardial infarction, PR depression in lead 2 can be atrial ischemia. Yeah, his blood pressure is only 99 though. So there's a question, is blood pressure and heart rate were higher? Yeah, of course. I mean, this is what you would expect when you stress somebody with an infarction.
And I think in this case, we made the diagnosis the inferior infarction. Sometimes it have the infarction of the right ventricle. And if we have the acute MI of the right ventricle, sometimes hypotension. So we need more fluids for the patient.
And remember, we already decided that he was dehydrated coming in.
But then when we were doing the stress test, when the ST segment was elevating, and the blood pressure dropped, he doesn't seem like he was in cardiogenic shock. He was not in distress at all. So that's why we keep the stress test going. And furthermore, we decided to do more, and the echo was done, and it was pretty normal as well, with minimal reduce in ejection fraction.
Infection before.
And that doesn't show anything as well, so we decided to do thallium imaging.
Why was his ejection fraction thought to be 45-50%? Was it global hypokinesis or was it localized?
It doesn't show hypokinesis. No localized hypokinesis.
Okay.
Because nothing was clear at this point as well, so a nuclear imaging was done as well, and that shows no damage in the myocardial.
Is it me, and does 14, 16, 17? I don't typically look at nuclear studies, but does it look like there's a different perfusion in the inferior lateral wall and septum? Dr. Tak?
We have two pictures, and then let's show the next one, the next nuclear scan. We have two pictures. See this one, the eye, the bull eye, show no reversible ischemia. Can we see the next one? Yes, this one clearer, and here clearly that we have no reversible ischemia. You mentioned about the inferolateral wall area in the 14, 15, and 16, but there was no frank picture of reversible ischemia, especially in a patient with chest pain and S elevation and in acute setting like that. And we have only very subtle changes. We don't have so drastic change of reversible ischemia, typical for a big infarction for STEMI with inferior lateral wall S elevation to VF and V4, V5, V6. And this is
Dr. Tak, it's still strange to me why we're trying to avoid a coronary angiogram here. This nuclear study can be compatible with a collateralized vessel, which is why he's having intermittent chest pain is also possible. And he may not be having an infarction. Who knows? I might be wrong. So to me, the best test is something where you look at the artery.
In this case, to say that does she have the question, the first one, the clinical presentation is quite strong. Chest pain, recurrent chest pain, even not typical. But the second one, he had EKG change so obvious and so strong and so beautiful. But the scan, the nuclear scan, show very subtle changes, almost. And by the computer reading, it was normal. You see? So
yeah, I don't know. Really, to me, when I'm worried about the arteries, I take pictures of the arteries.
I understand.
I think, in my opinion, I agree with Dr. Pinto, because in the patient with elderly patient with the cardiovascular risk factor, hypertension, hypercholesterol, and particularly we have another diagnosis, maybe spasm of coronary artery disease. So after its dilation, you now finding in the nuclear imaging. Because
what about let Nhân or Lộc, would you show the EKG in the, during the stress test?
Yes, okay.
Right.
Yes, this one. Okay, this one. Now you have to explain your rationale. Is it more likely pericarditis, or is it more likely acute MI? You have to show the rationale.
I'll tell you, Dr. Tak, I'll know exactly the answer to that after I do an angiogram. If the artery's open, it's not MI, and if it's closed, it's an MI.
Okay.
That's why it's a better test.
Yep, I know. So, can you explain this one?
Yeah, I think it would be very atypical, and it would be not the standard strategy to do a stress test on somebody with ST segment elevation, even if you're worried that it's not an MI and it's myocarditis. This would have to be focal myocarditis, focal pericarditis, or vasospasm. Either way, the best thing the time-dependent diagnosis to rule out is STEMI. So the time it takes to do the stress test and the nuclear test and all that sort of stuff is all wasted time if we're wrong.
Hello, Jen and Lộc,
Yes.
can you explain the rationale of yours when you look at this EKG?
We find out that in the acute myocardial injury, the ST elevation always by the degree action potential of amplitude, right? But in the pericarditis, the inflammation directly affect the epicardium beneath it, cause the ST elevation, and since the pericardium is all around hot, so the ST elevation usually diffuse in all the lip.
That's right.
in my opinion, about the history of the pericarditis, it's more widespread at the elevation, and it keeps at least some day to change. But acute ischemia, the history change dynamic very quickly. And I think in this case, you should record history 1 hour again, 1 hour again. I think it's very, very, very a little bit history in here. Very difficult to do interpret. Sometimes
the question of leukocytosis is brought up again. You know, MI used to be diagnosed by elevation of the white blood cell count because it's an inflammatory situation, and it's an acute phase reflection. This is a little bit high than you would expect, but he was also hemoconcentrated at this time. So elevations, remember, his white blood cell count was 19 and his hematocrit was 50, But remember, before we had CKMB and troponins, and white blood cell count elevation used to be something that was one of the diagnostic criteria for MI.
So at the first, in this EKG, I will interpret it again. During over the stress test, the PR depression and in general, the signs in EKG for pericarditis shows more prominently than MI over the course of the stress test. The PR starts dip more than the SCA elevation in many leads, and also the T waves in many of these leads doesn't show specific characteristics in MI. It doesn't show very high T waves as well. In 6 hours, it doesn't show a Q wave as well in the leads we're looking for. So MI is very unlikely for this. I think.
I think the first you should have an ECG for demonstration. You cannot do interpretation without the ECG.
Yes.
And
I
yeah,
agree.
and pericarditis when you do stress test it no change. And the Q wave for necrosis maybe not appear because maybe it's close and spontaneous some fibrolysis, and so the Q wave not appear. So I think in this case we must do coronary angiogram before we make definitive diagnosis.
So let me explain what Nhân mentioned. So the first, when we have an acute MI, the first picture it is we have the tall hyperacute T wave, tall T wave, and then the second one, it is the second sign. It is the ascending limb of the T wave will move closer to the QS complex. This is the second one. And then after that, we begin to have S elevation. And at that time, the QS complex, the T wave become one. So we have the QRS T wave complex. In this case, in the EKG, clearly we have S elevation, but we don't have the fuse of the T wave with the QS complex. This is, it shows very clear in lead 3. So this is it point more about more toward the pericarditis, and then we have deeper and more diffuse PR interval. T wave. Yep, PR interval depression compared with the TP segment, and this is this is what we just talked about the interpretation of the EKG in this case.
Yes, I agree with you, Professor Thượng. But sometimes in the acute coronary syndrome, the role of vasospasm or sometimes spontaneous thrombolysis, it makes the ECG not typical develop. But in this case, I think it's a difficult case.
It is, yeah. And it's an atypical presentation because he has negative troponin, abrupt onset of chest pain, and a normal EKG. And then all of a sudden, he has severe chest pain again. He's tachycardic, and the EKG is worse. So, look, reasonable people can disagree. That's why we disagree.
So I understand. I agree. Very important for the clinical physician when he is there to have a sense of what's going on. Is it cardiogenic shock because we had low blood pressure? Is it STEMI? Is it chest pain? Now, one thing important, the troponin level.
So this has been brought up before too in this discussion, Dr. Tak. You know, just the blood pressure alone doesn't rule in or rule out cardiogenic shock, but he's not congested. Their lung exam is normal. He's not hypoxic. So any hypotension is unlikely to be cardiogenic because his filling pressures are not seemingly elevated. But, you know, he's asymptomatic with the blood pressure of 86, 99. He's just having chest pain. So, you know, even if his blood pressure was 80, I wouldn't worry that he's in any sort of shock.
Yes, I agree.
You know, and the blood pressure changing from 86 to 99 to 100 during the stress test, all of that's insignificant.
It's okay. So, because the result of the stress test, the thallium scan was negative, or very minimally abnormal. So he did not. He was not. He was not asked to have an angiogram. Now the question we have is: so, what can show whether or not he had acute MI or not? So. Next level, the next day troponin level will help. Does next day troponin level will help?
Oh, I mean, it doesn't tell you whether he has an occluded artery or not. It tells you whether you missed an infarction. If he still has ST segment elevation, we have to explain why. And if he's still having chest pain, we have to explain why.
I think the serial troponin test to make the diagnosis acute MI, but in the case of the pericarditis, acute pericarditis, sometimes inflammatory process happen in the epicardium, and sometimes the troponin still rise. Yeah.
So the question was brought up whether we would start heparin. You know, to me, you either worry he has an acute coronary syndrome and a thrombotic problem, and you treat it as such, or you don't. So in keeping with the strategy that was selected, you wouldn't start heparin because you don't think it's an acute coronary syndrome, because we're not treating it that way. So, you know, I think you have to be all in. You can't, you know, treat it halfway. If you really thought it was somebody that was having an acute coronary syndrome and you want to start heparin, then that person should be in the cath lab. If you're deciding that's not what you think the most important diagnosis is for the patient, then you wouldn't.
Dr. Thật, Professor Thật, I think it's not enough time to discuss another topic. So maybe
it's okay. So just very simple, we give the patient non-steroid anti-inflammatory drug, and he improved a lot. And the next day, with the everything's negative, and we suspect that can he have pericarditis due to COVID. So we checked the COVID, and it was negative, and he went home happily. So this is what happened.
Is he still alive?
Oh,
he might have gone home happily, but is he still alive?
The key wave in this case, it is the T wave. Ascending limb did not move to the Q complex. So this is why we feel so confident that it is not ACS. And
I would feel much more confident if his coronary arteries were normal, Dr. Tak.
I agree with you too. Okay, but you know that
and,
in the
and can you explain why? Can you explain what did he develop pericarditis over the 8-hour period from the emergency department to when I assume you're the senior cardiologist because you know very much about it, but you know it seems to me that he wasn't having chest pain, then he had abrupt onset of chest pain and EKG elevation. I understand the contour of the ST segments, but this would be very strange for him to have developed pericarditis while in the hospital. I suspected something was strange because he was a white man, being presented in Vietnam. So, that was a little strange as well.
Yes, he is having acute pericarditis at first, but then his EKG didn't change until like 4 p.m. in the afternoon, because in pericarditis, the EKG can take hours or days to change.
Yeah.
But his chest pain is so atypical as well, because pericarditis chest pain is a lot more typical with like
periodic chest pain, yeah.
He could very well have an occluded RCA that is collateralized from the left, and that's why he has intermittent chest pain and ST segment elevation. That's very common.
I agree. So let's finish this one because we don't have a lot of time. Let Dr. Dũng present the Vietnam guideline about CAD during the COVID outbreak.
Okay.
Yeah, okay. Thank you for listening.
It's very nice. Thank you.
Thank you.
And you know what? This is a much more instructive case when it is not typical and very senior cardiologists disagree about the management. It's a much more meaningful case, and a case that shows you that there's not a correct answer in every case. And there are some very subtle differences. Obviously I have a bias because I'm an interventional cardiologist. So I'm obviously much more interested in interventional cardiology stuff. Now, Dr. Tak is a very experienced interventional cardiologist as well. But what is the most important thing is he was there with the patient and could examine the patient and talk with them. And the impression that he got was that this was not something that warranted an angiogram. So I can abstractly hear about the patient and offer opinions, but you can see that it's much more important to be with the patient.
Thank you very much.
Thank you very much.
Okay, but now I present the perspective of Vietnam National Society of Interventional Cardiology about imagine PCI in the acute coronary syndrome during COVID-19 pandemic. The first, I'd like to say something about the policy of Vietnam during COVID-19 pandemic. First, our resources are rather limited. So we try to do active controlling the outbreak of the pandemic for buy-in pressure time for preparation. So far, until now, we have to do many preventive measures. We do very early, very strictly for social distancing, minor and major restriction, isolation, quarantine, lockdown and lockdown, some districts, some province, and all the country. And on the level 1 or level 2 of the pandemic, we treat the infected COVID-19 patients in the hospital specialized in infectious disease, not in general hospital. Such as my hospital in the general hospital, we don't treat the COVID-19 patient. If some patient are positive, we send the patient to the tropical disease hospital. And the whole Vietnam work as only one network led by the government and Ministry of Health. So the Vietnam National Society of the Interventional Cardiology issued the consensus how we do emergent reperfusion therapy for the patient with positive or probable positive COVID-19 patient in acute coronary syndrome. We issued very early about the 1st March. It means in that time, the epicenter of the pandemic in the Europe, Italy, Spain, are not touched to America. So the strategy of reperfusion therapy in ACS or QMI during COVID-19 outbreak is combination of the first principle of acute reperfusion therapy of ACS AMI I think this principle every cardiologist, interventional cardiologist have learned and done. We combination of this principle with policy of control of COVID-19 pandemic of Vietnam. All the government and healthcare system are doing. And do you know, so far, we have a lot of the Vietnam hospital were locked out or locked down. This is the list. Hanoi obstetrics and gynecology, we keep 83 healthcare workers for quarantine. Hanoi Central Hospital, Hanam Provincial General, National Hospital of Tropical Disease, National Institute of Hematology and Blood Transfusion. We keep 45 healthcare workers for quarantine. E-Hospital for Person, Hanoi, French Vietnam Hospital, 22, Phúc Yên Regional General, and Đức Giang Hospital, 18 healthcare workers kept in quarantine. And particularly, we locked down totally But My Hospital. I think Professor Pinto, you know, But My Hospital. Inside, we have the National Heart Institute. We locked down totally for 2 weeks. We locked down totally Hanoi Hồng Ngọc Hospital for 2 weeks. Hanoi Nephrology Hospital locked down for 2 weeks. So, the Vietnam National Society of Interventional Cardiology give the consensus on PCI in acute coronary syndrome and acute MI. The first approach, we have 3 approaches. The first approach, we try to delay in or rescheduling elective PCI for positive or probable COVID-19 patient. The patient have a confirmed negative test for COVID-19 or he passed quarantine duration with 2 confirmed negative tests COVID-19. We do have, until now, we do not have the fast test kit. Then BCI will perform usually in the cath lab. So, which situation? The first, non-STEMI with stable clinical setting. STEMI with stable clinical setting and beyond past the golden time. STEMI with successful fibrinolysis therapy. This is the first approach. The second approach, emergent reperfusion therapy for positive or probable COVID-19 patient. Priority emergent reperfusion therapy with non-intervention measure. They are performed at isolation department. Non-STEMI with stable clinical setting, they receive OMT, optimal medical treatment first. Coronary angiogram and BCI will perform after confirmed uninfected COVID-19 or being past the quarantine time duration with 2 confirmed negative tests for COVID-19. The STEMI with stable clinical setting during the golden time are considered for fibrinolysis therapy. Coronary angiogram and BCI will perform after confirmed uninfected or being past quarantine duration. The STEMI with unstable clinical setting is the first choice for primary BCI. However, in the case of infeasibility, fibrinolysis therapy could be considered. And the third approach, emergent or primary BCI for positive or probable COVID-19 patient. In the case of no choice, emergent primary BCI should be done. They have done a dedicated COVID-19 cath lab. We have a situation, some situations, STEMI with unstable clinical setting, certainly cardiogenic shock or compromised hemodynamics. STEMI being hospitalized during golden time with contraindication of fibrinolysis therapy. Non-STEMI with unstable clinical setting, cardiogenic shock or compromised hemodynamics. And when perform imaging of right beside for infected or probable COVID-19 patient, we should keep in mind two things. The first, dedicated COVID-19 cath lab fulfill criterion of operation theater for infected probable COVID-19 patient according to Vietnam Ministry of Health. It means the dedicated cath lab room with negative pressure, PPE for all staff and personnel, and the suitable disinfection management. The most cath lab in Vietnam do not fulfill this criteria. The second thing, when transfer patient to the cath lab is considered, it should be due cognizant of the overall implication, not simply based on the patient risk benefit or operator preference. Okay, thank you so much. This is the consensus of the Vietnam National Society of Interventional Cardiology about emergency BCI in the patient with acute coronary syndrome during. Yeah.
Well, that's very nice. It really highlights the need for people who understand the local situation to develop the guidelines, because many of the guidelines that apply in one area do not apply in another country. Our guidelines are very similar in the United States, and there's actually been some conflicting guidelines that have been put out in the United States, and somewhat different than what was in China, and different, again, what is suggested from Italy. Almost everything is quite similar, but something to think about is the administration of fibrinolytics in patients who are low risk is a matter of debate when there's COVID positive or COVID suspected. And I think one important thing to think about, two important things to think about, is the severity of illness from COVID. So there's COVID and I have the sneezing. And then there's COVID and I have profound ARDS and pneumonia, in which case a small infarction or a small inferior infarction, for example, the case that Dr. Tak showed, even if it was an MI or not, that's not a big infarction. It's not somebody who's going to die from that, but they might die from their COVID. So I think that's the first decision, is how severe is the MI, and balanced about how severe is the COVID infection. And then the low risk patient, I would actually suggest not to do fibrinolysis in the low risk patient, and maybe not to do anything because of the risk of intracranial hemorrhage. And if there's a risk of 0.75 to 1% risk of intracranial hemorrhage, I think if it's an important infarction, we should just treat them with primary PCI. And you outlined that we still have to be prepared to do it in the sick non-STEMI patients, in the sick STEMI patients, with protective PPE and all the measures that you outlined. So I think that, just like I said earlier, the safest place for a person to get reperfusion therapy is in the cath lab. And the safest place for somebody to get reperfusion therapy, if they don't have a STEMI, is also the cath lab, because then we know not to do anything. So the risk of bleeding is compelling to me because of the risk of intracranial hemorrhage. So that's the only difference in our practice. But otherwise, we're doing the very same things that you are. We're waiting on the non-STEMI patients and ruling them out for COVID if they're stable, and bringing them later. We have protocols like you do. And I'll share my screen here. Let me see if it's showing here. I don't know if you see it. 1 second. But our protocols involve having a limited amount of staff. We try to have one operator in the cath lab rather than a number of trainees. We try to keep the technologist in the control booth, not in the room. And I'm sorry, my desktop is not showing. But, this is a problem because our room is not available. Our COVID positive room is not available for at least an hour or two between cases. And one of the other issues is that we don't have a negative pressure room. As you mentioned, most cath labs in the United States are not negative pressure either.
Really? Yeah.
May I ask what the PPE is that you use in your hospital?
Yeah, the mask N95 and all the gown and the shield cover the face. Yes.
Yeah.
And fortunately, fortunately until now, we have no case for in the situation cardiogenic shock or hemodynamic compromise. Because if we do, we say his line, the cath lab maybe were locked down by the Ministry of Health. Because by now in Vietnam, if in the hospital, transmission between the patient and the healthcare worker, if the transmission are 2 or 3 persons, the Ministry of Health lock out one department. If the transmission between healthcare worker to healthcare worker to healthcare worker lock down totally the hospital.
You can lose many people.
If we say one man, all the heart team were kept in quarantine, and we can do nothing. So we must keep workforce.
Yes, we've been working in teams. So one team at a time, so that for that reason, if we lose one team, we don't lose everybody. People don't sit together for lunch. In those teams, they don't. We're keeping separated for that reason. It's a very good. This is just our schema for the preparation phase, the cath lab phase, and after the cath lab of how we handle the patient coming in, and when the PPE is. And I'll just highlight a couple of things. Is we wait 30 minutes after the room has been done to do a terminal cleaning. We have somebody watching us put on the PPE to know that we do it correctly. Again, we have our fellow in the control booth until the time comes that we really need a second pair of hands. But this is the recommendation for primary PCI that we have suggested. And this also comes from Columbia University, my friend Ajay Kirtane. But you see, in the yellow, green, and red, it depends on your situation. Right now, we're in the yellow situation. We started off in green, but you may come to a situation where it's a crisis. And as you mentioned in your guidelines, if the hospital, it's not feasible to do primary PCI, then you do fibrinolysis. But so far, we've been in the yellow situation where we're discussing and doing as you are, which cases. Now, when you hear from other situations of they used fibrinolysis in all cases, that's because they were in the red zone. They were overwhelmed. There were too many infections. There was too much going on, and there was not enough cath labs. So these kinds of things are very important because this is a new way of deciding what to do, because we have two additional factors. Is our cath lab available, and how bad is the pneumonia? The patient has a competing illness.
Okay,
this is our pathway. And I'm happy to email these to you. And even now, Dr. Dung, I will also send you slides because we're seeing the other side. And now that we have stopped everything, we've shut down the hospital, we've shut down about 90% of cardiac catheterizations. How do we restart? And our nurses are all in different places. We don't have enough staff. Should
Yeah.
there be one COVID positive unit, cath lab, or 2 or 3? How do we keep the uninfected patients safe? So that's the next thing that we're working on, is how do we restart?
So we say each other, no room for hero, just only obeying or complying the rule. Yeah.
Yes, I agree with that. And it's an important point that you make, because you need to stop us from ourselves, because all of us, if there is a sick patient, would just go into the room and not protect ourselves. And the most important thing is to spend an extra 5 minutes to protect yourself and your staff.
Okay, thank you.
Are there further questions or comments? Anybody from the audience? Dr. Tak? What do you think about this?
Thank you very much. And I really happy with you today and Dr. Dũng. And the key it is the rationale, how we arrive to a decision and not to arrive at a decision. It's very important, because when you look at the case from the ER, how to with physical examination, how we can rule out a dissection already. This is very important. So it is for us, for the student to, or for the young doctor to learn a thinking process in the case. It's not just the result. By chance, the result come out that way. But I say that, like, again, I have another patient with like you have every day. We have every day patient with chest pain coming in, and we have to make decision because we don't want to rush a cardiac cath lab team, and then we cause a mistake. You see, let's say, for example, the patient is COVID positive. It can contaminate everybody, you see, and everything.
Yeah.
So this way we have to be very careful. So from my part, I say that the learning process is more important than what's going on here. And this is very important. And Dr. Dũng, he shows the guideline from Vietnam, and you show the guideline, and very beautiful with the color. The usual situation, the contingency situation, and then the crisis situation. This is very beautiful to see that, you see. In Indiana, we have cases of, I have, in our hospital, we have 17 patients with COVID positive. And so maybe 5 in ICU, and I have 2 with positive, but we don't have, they don't overwhelm all our ICU system. We still have enough room, we have enough ventilators, and we use the PPE very carefully. So this is my comment. And thank you for being here, and thank you, Dr. Dũng. Dũng, do you have anything last impression before we can go? And Dr. Pinto, you have a last comment before we go?
I think yes. The first, I appreciate Dr. Pinto comment about the consensus of the Vietnam Society of Interventional Cardiology, because we are in favor of fibrinolysis therapy, but no choice. If we try to say someone, I think all the cath lab, all the hospital were locked down. But very, very lucky, fortunately, until now, the COVID-19 pandemic not outbreak in Vietnam. So we must not face in the situation, rescue or save the patient or not save the patient. But I think in some countries, look like Europe, Italy, and even in the US, sometimes we must try between save the line or not save the line. I think so. Yeah.
I think I just want to leave you. I'm going to show you a chest X-ray of this patient that I put on ECMO today, and it may seem abstract, or why are we doing this and why are we worrying so much when you don't see that many infections. But we have 200 patients in our hospital, and some are like this gentleman who is 50 years old. He has no other medical problems, and this is his chest X-ray. I don't know if you can see it here. Can you see the chest X-ray?
Yes, we can see it.
Okay.
So you see, and this is somebody who's otherwise healthy. This has occurred in the last couple of days, and we have, you know, dozens of patients like this. So you are saving people's lives by following the protection and the lockdowns and all the things that you're doing, because you don't want to have patients like this if you can avoid it. But you see diffuse, you know, alveolar pattern. You can see the ECMO cannula. The return cannula here is in the SVC terminating the RA. And this is 2-site veno-venous ECMO with another cannula here in the abdomen. And that's because this young man had refractory hypoxemia despite full ventilatory support and being prone. And either we were going to do this to try to save him or not. He's the first person we've put on. Most of the patients we've been able to avoid this. But you can see he has a pretty horrible looking chest x-ray.
Yeah.
So I really very much enjoyed being with you. I hope you invite me again. It was very interesting, and I love to learn from all of you. Thank you.
Okay, thank you so much, Professor Duane Pinto, and thank you so much, Professor Thạch Nguyễn. You give me opportunity to take part in very interesting meeting today with all of you. Thank you so much.
Thank you.
Thank you very much, and good night, Duane.
Good night.
Okay.
Good morning, Vietnam.
Good morning.
Thank you. Thank you. Good morning to you guys.
Okay.
All right. Bye-bye.
Bye-bye.